Hello, everyone. My name is William Patterson. I'm one of the orthopedic surgeon shoulder specialists at Ortho Arizona. And today we're going to be talking about evaluation and treatment of rotator cuff tears. So a quick overview of anatomy. The top left picture shows the front view of the shoulder. The middle picture shows the back view of the shoulder, and the bottom picture shows a side view of the shoulder. The rotator cuff muscle tendon basically means the same thing. The tendon is what connects the muscle to the bone. The rotator cuff is created out of four different tendons: teres minor in the back, infraspinatus, supraspinatus on top, and subscapularis in the front. The biceps tendon in the front of the shoulder and arm is not part of the rotator cuff, but it does attach into the shoulder socket, so it can be a common source of shoulder pain. The history is the most important part of trying to diagnose shoulder conditions, and out of that, the age of the patient is the most important thing that helps you decide what the most likely problem is. We'll see that more a little bit later. Also, obviously important is the mechanism of injury. Was it from an obvious incident, or is it something that developed over time? By far, most rotator cuff tears are quote unquote wear and tear or things that develop over time. The location of the pain is important, as we'll see in a minute, and then of course any associated symptoms. So location of the pain, I try to get people to pinpoint the exact location where they feel the most pain or where they feel the pain during certain movements. This is just a quick overview of many different things that could be related to shoulder problems. One thing that you'll notice is that in basically every single location, nerve is a possibility. So whenever I'm seeing anyone for any shoulder problem, potentially a nerve-related problem is on my mind. Physical exam, very brief overview of physical exam. We start with elevation or flexion, basically how far can you raise your arms up in front of your body and overhead. External rotation with the arms at the side. Internal rotation with the arms up the back. Strength. The supraspinatus part of the rotator cuff is most active at around 30 or so degrees of elevation, so this is the best way to isolate the supraspinatus to test for that strength. Infraspinatus is more external rotation with the arm at the side. And then subscapularis, there's two subscapularis tests. The one on the left is called a belly press. So a positive belly press would be if the patient cannot move their elbow away from the side. And then the other test on the right is called liftoff. So if you cannot lift your arm off of your back, that would be a positive liftoff, indicating a possible subscapularis tear. So there are many different factors involved in what contributes to a rotator cuff tear. And at this point, really, we're talking about more the chronic wear and tear. Obviously, if someone has a fall that creates a rotator cuff tear, that's a separate issue. So one of the main things that has been considered as to why people do tend to develop rotator cuff tears without an injury is that this part of the rotator cuff on top here, you can see that part of the supraspinatus correlates to this circle on the side view, has a very poor blood supply. And so it's quite common that most of the wear and tear rotator cuff tears start in this area. We talked about age. It's actually quite questionable whether overuse or repetitive use of the arm causes rotator cuff tears. Steroids we'll talk about. Smoking and even high cholesterol are also risk factors for developing a rotator cuff tear. And then things extrinsic to the tendon, so different things that can potentially cause damage to the tendon itself. It's actually quite debatable whether the bone spur, everybody talks about a bone spur on the top of the shoulder, is the cause of the rotator cuff tear, or, as this example shows below, as the rotator cuff tendon continues to thin out from left to right, it's actually possible the spur could develop as a result of that. Rotator cuff tears are common. This study on the top showed in cadavers up to a 32% incidence of partial tears, up to 20% incidence of full thickness tears. Obviously, we don't know if these cadavers were having any sort of pain or symptoms or not. But in these other two studies, in hundreds of asymptomatic patients, so again, patients who had absolutely no shoulder problems, about 17% of them had a tear in at least one shoulder. And then again, this study below wasn't quite that high of a number, but it's quite astounding. There's probably, after age 60, probably at least 10 to 15% of the overall population has a rotator cuff tear. And you can see again over here that as age goes up, clearly the incidence of rotator cuff tears, this is including full thickness and partial thickness rotator cuff tears, up to 40% of people have rotator cuff tears and don't even know it. So when I see patients with rotator cuff tears, we have several treatment options. Generally, for smaller chronic tears, starting with conservative treatment is very appropriate. Physical therapy has somewhere around a 50 to 75% success rate for giving pain relief for, again, chronic atraumatic rotator cuff tears. Corticosteroid injections, quite debatable. We know that every time we do a cortisone shot, it does temporarily weaken the tissue in the area of the tendon. And then if you have a cortisone shot and end up having surgery, cortisone is a risk factor which increases the rate of failure of a rotator cuff repair and also increases the risk of infection, especially if the cortisone shot is performed within 1 month prior to a rotator cuff repair surgery. Toradol injection possibly is safer than cortisone. It hasn't been shown to have the same side effects. However, it definitely is not as effective as cortisone for pain relief. And then, of course, there's platelet-rich plasma injections, also known as PRP, and stem cells. There is very little data. Clearly, these injections will not help a full-thickness rotator cuff tear. There may be a very small subset of intratendinous partial rotator cuff tears, which could actually be helped. And there are actually studies ongoing right now looking at this. So what do I do? Generally, in patients over 70, and again, that age is a rough cutoff, especially if they have a very large tear, I will start with conservative treatment and exhaust conservative treatment, which means maybe doing an occasional cortisone injection and physical therapy. If a rotator cuff tear is the result of an acute injury, and also in patients under 70 with a repairable rotator cuff tear, we're going to at least talk about surgery, because with a full thickness repairable rotator cuff tear, surgery clearly provides the best long-term solution in terms of pain relief, strength, and function. I personally do arthroscopic transosseous rotator cuff repairs, and as we'll see, this is biomechanically at least as good as the other techniques. It is cheaper than using suture anchors, and there have been some studies that show a better blood flow to the repair site with transosseous technique compared to the standard anchor-based technique. So we're going to look at this video. This is arthroscopic shoulder surgery. What we're looking at here on the top is the biceps, the labrum that surrounds the socket of the bone, and the humeral head over here on the right. Turn the camera, here's the rotator cuff. So you can see there's some degree of fraying and tearing of the rotator cuff. And as we go back further, this is the rotator cuff surrounding the entire ball. This is actually all normal rotator cuff tissue further back. Clearly in this patient there's some fraying and tearing of the biceps tendon as well here. So that's a real quick visualization of the intra-articular or joint part of the shoulder. Here is the subacromial space, so this is the space outside the joint. Basically what we're looking at is down on the top part of the rotator cuff. So this will be subscapularis in front to supraspinatus, And here you can see the partial tearing of the rotator cuff, infraspinatus, and then all the way down to teres minor. So this is like that side view of the shoulder from the anatomy picture in the beginning. You're going to see the probe come in, and again, you can actually see this patient does have a small full thickness rotator cuff tear where the tendon is completely detached from the bone. There we go. So what we do next is clean it up to get back to healthier tissue and also clean bone underneath. So that's what we're looking at now, is that the tear is cleaned up and the bone is prepared to provide a good healthy bleeding surface for the repair. Again, this is the rotator cuff. That's the torn tissue that is going to be fixed. Basically showing that I can easily take the tendon down and fix it with little difficulty. Again, the different repair methods. So the first two, single row, double row, are anchor based. You actually place anchors inside the bone with stitches that are attached to the anchors that are used to compress the rotator cuff down to the bone. Single row, the problem with single row is, again, it's a single row of anchors. It doesn't provide as good compression of the rotator cuff to the bone. It has been shown to have a higher risk of failure after repair compared to double row or transosseous. Transosseous, again, osseous meaning bone, so there's a tunnel that goes through the bone. The stitches go through the tunnel and are tied, again, compressing the rotator cuff onto the bone, quite similar to this double row type technique. So we're going to be viewing a transosseous rotator cuff repair. First part is to drill the tunnels. So first you drill a tunnel and put in the instrument, which helps direct another drill from the outside. So again, what we're looking at is a tunnel that starts here and goes through the bone and comes out at the inner edge of where the rotator cuff is going to be attached. This suture is called a shuttle suture. It's basically just a loop. We're going to use this single suture to shuttle 4 repair sutures through this tunnel. So here's the shuttling. Again, the same suture. We're going to grab that out a different portal and use that to shuttle the 4 strong sutures, which again are going to be the stitches that we use to repair. I'm placing a protector to prevent the sutures from actually cutting through the bone, because believe it or not, these strong sutures actually can cut through soft bone. So this little plastic tube helps prevent that from happening. So here we're going to be watching the passing of the stitches through the rotator cuff. So these are the instruments that we use that actually takes the stitch and places it through the rotator cuff tendon. And my assistant will grasp the stitch through another portal to keep them separated. We're going to do this with all 4 stitches. You can see there's 2. This is the 3rd one. So we do that with 4 stitches. And once the 4 stitches are all passed, then we're going to grab each end of each individual stitch and tie it down. Again, what this does is it brings the tendon and compresses it to the bone, so the actual healing occurs between the tendon and bone. So again, the tendon is going to heal back to the bone where it had torn off of. Obviously, there's various arthroscopic instruments specifically designed for this purpose to tie the stitches, grasp, and cut the stitches. So again, all 4 stitches are now tied, and again you can see where that rotator cuff is now attached to the bone, and over time, 6 to 10 weeks, it will heal to the bone with a healed rotator cuff repair. This is a very brief review of what happens after surgery. The surgery is typically done as an outpatient with general anesthesia as well as a regional nerve block or intrascalene block performed by the anesthesiologist. One of the common complications is hypoxia. This is typically related to the regional block because the regional block involves the phrenic nerve. This will typically wear off and return to normal when the nerve block wears off, which could be anywhere from 12 hours to a few days. Most people tolerate this very well. However, occasional people with pre-existing lung-related conditions or sleep apnea will have hypoxia to the point where they need to be admitted on oxygen until the block wears off. Also, when the block wears off, people will experience pain. Usually, most patients need narcotics for anywhere from 2 to 7 days, sometimes a little bit longer than that at night because it is uncomfortable at night. But typically by a couple of weeks after surgery, the pain is controlled with ice, Tylenol, ibuprofen. I always have patients wear a sling, usually with an abduction brace for about 6 weeks for a small or medium-sized tear and 8 weeks for a larger tear. Usually start physical therapy around 2 weeks after surgery for passive range of motion and home exercises, progressing to active range of motion at week 7, and by week 10, pain-free strengthening. I tell patients to expect to be able to do more with less pain by 3 months after surgery, but the full recovery can literally take a year as the arm continues to improve and get stronger. Thank you very much for your time. If you have any questions about this presentation, or if you have additional ideas for topics that you would like to see presented in the future on My Journey videos, do not hesitate to email me. That's my email. Also, if you do have references or want to see the bibliography that I used for this presentation, just let me know. I'm happy to provide it. Thank you very much.